Bueno, el caso se trata de una femenina de 20 años de edad. Tiene un índice de masa corporal de 31 y como antecedentes personales se colocó un doble J derecho en otra institución. Vino a nuestro centro por dolor lumbar izquierdo y fiebre. Y la tomografía nos muestra que en el riñón izquierdo un cálculo de 9 por 7 milímetros en la pelvis y otro cálculo en el cáliz inferior de 4 por 4 por 5 milímetros. En el corte coronal, el catéter derecho normoposicionado. Remarcamos los cálculos nombrados anteriormente. Se le realiza la extracción del doble J derecho y se coloca un doble J izquierdo. Esta es la radiografía del árbol urinario. Vemos el catéter normoposicionado. La función renal de la paciente está conservada, tiene un urocultivo positivo, recibirá un antifúngico previo al procedimiento. Actualmente se encuentra asintomática.
Silvia, can you hear me?
Yes, I can hear you, dear colleagues, dear moderators. Good morning. It's a great pleasure and honor for me to be here today and to perform a flexible ureteroscopy. So before starting, I would like to thank Professor Norberto Bernardo for the prestigious invitation and also all the team, the medical team who are assisting me. So we are a female team, as you can see. I have Paula, the scrub nurse, and Eliana. She's my assistant. So let's start directly with the flexible ureteroscope. Today I will use the red pine single-use 7.5 French. And I want to repeat what I do in my OR. So I start directly with the scope, and I will place the guide wire, and then I try to remove the stent by using the flexible ureteroscope. Can you see the endoscopic image? Perfect.
Yes,
Okay.
yes, we can
So
see.
the bladder is empty. So let's use the guide wire. Paula, please help me. Okay. You see? From up. Okay. So the working channel of the flexible ureteroscope is at 9 o'clock. So let's try to do our best to negotiate the ureter. So please, you have to push. Yeah. Okay. Look at that. Okay. Okay. Go, please. Okay. Okay. Super. Okay. X-ray, please. Slowly. Okay. Go. More. X-ray. So I want to see a little bit down. Keep it. Okay. Eliana. Okay. Stop. Okay. Okay. Super. Now I remove the scope and please take the guide wire, Eliana. Okay. So perfect. Right now, so is water, please. Okay. Wait. Thank you so much. So the coil. Okay. So I will place my guide wire inside the coil. And the tape, please. Okay, you can see from the auditorium?
Yes.
Can you hear me?
Yes,
okay,
we are
perfect.
listening.
So safety guide wire, safety is never enough. Okay, and let's start again. Okay, basket ready.
Dr. Proietti, good morning.
Yes?
I'm Dr.
Good
Varea.
morning.
Good morning.
Good
You
morning.
performed a ureteroscopy, rigid ureteroscopy before the
Never,
procedure?
never if I don't need to perform semi-rigid. So I mean, from above? Okay, super. I mean, in the majority of cases, I use the flexible ureteroscope also for the ureter. And I will show you as I perform the ureteroscopy by using the flexible ureteroscope. So this one here, okay. Open the water, okay. So I use, the semi-rigid, open the semi-rigid ureteroscope when I know that the stone is in the lower part of the ureter. So let's try to close. Okay, so the guide wire, super. So open, okay. So the stent is out, throw away, okay. So in this way, I can skip the step of the cystoscopy and the semi-rigid ureteroscopy. Let's try if I am able to enter inside the ureter directly. Eliana, when we are just in front of the urethral orifice, you have to push a little bit more, okay? Water, irrigation, please. Irrigation, irrigation, irrigation. So the ureter here is not so nice, honestly speaking. So I don't want to force. And what I want to do is to backload my scope on the guide wire. Okay? So keep it. No, not the laser. Keep it. Okay. So I need, please, close the water. Okay. I need, please, the X-ray down. So it's strange because the lady has already, okay. Keep it. And this one, Eliana, okay. Like this. Okay, perfect. Okay. I was telling you that it is strange because the patient had already the stent inside, and the scope is 7.5. So I don't want to force, remove the irrigation, and we use the scope as a catheter. Keep it, keep it. Okay, so like this. Okay, water on the guide wire. Okay. Parallel to the floor, fantastic. Okay. So in medicine, you never know. You have to have your plan B, plan C always ready. Okay. Keep it and don't move. Huh? Okay. No, I have to see. No, on the bladder, please. Yeah, okay. So now I have to remove the guide wire. So we have to keep in mind that we don't have the guide wire, the safety guide wire. Okay, slowly, slowly. So I didn't force, but it was necessary, yeah, to enter inside the kidney. Okay, okay. So let's go ahead. Okay. Okay, where is the stone? Okay, here it is. So what we have to keep in mind that we don't have the ureter access sheet because only just a moment, I don't want to force with the ureter access sheet. We don't have the safety guide wire. So what I want to do is to perform a dusting of the stone that I have in the renal pelvis. But honestly, I don't want to remove any fragment. So I want to do my best to perform come with the laser. Okay, to perform a dusting technique, even though sometimes it's not really possible. Let's see. I will do my best. I want to ask the anesthesiologist if it is possible to decrease the breath of the patient, not apnea right now, but just a little bit less end-tidal volume. Okay, I'm using the Jena laser. I have my friend, the Italian friend Pietro, so he's supporting me with the laser. I would say let's start with 0.4 and 20 hertz. I will just taste the stone. And the long pulse, please. So during the laser tripsy, I would need a little bit less end-tidal volume. Start, please. Yeah. Yeah. Let's start. So the dusting technique is to perform a painting of the stone on the surface.
Laser we're using here. What laser system is this?
So it's an all-New-York laser. The name of the laser is Jena surgical laser machine. Is a German. I'm asking to Pietro because I don't use the Jena laser, but it's super. I know that it's, and I'm watching the video. It's super good laser, all-new laser. And what is nice is that the laser fiber, the core is really at 272 microns, and compared to other companies, and moreover, the long pulse, the length of the pulse of the long pulse is super long. Is 1,700 microseconds. Sorry, and so I'm doing, I think, a quite good job, and I'm performing a dusting technique, but slowly. I don't want to rush, and because otherwise, if I will have fragments inside, so it would be really demanding in a ureter like you saw before. So
Silvia?
Hi, Silvia. Glenn
Yeah.
Preminger.
Professor, good morning.
Good morning. It's great to see you, and congratulations on getting up the ureter so easily and getting to the stone. Can you tell us a little bit about your irrigation system, and do you have any concern about high pressures in the kidney now that you don't have a ureteral access sheet?
For sure, Professor. I am a little bit worried about the internal pressure, because we know that if we use the ureter access sheet, the pressure will decrease for sure. So as you can see, I'm not sure that you can see the external part. The irrigation, the bags are just, I would say 40 centimeters of water above the bed of the patient. And so for sure, we are not sure about the internal pressure that I'm developing inside the kidney. But you know, this patient had already the stent. So how we can perform the surgery? Maybe a solution could be to perform a mini perk. But let's see what I am able to do. The stone is quite hard inside, and we are using the T-flow, is an irrigation system with a gravity system, but Eliana, my assistant, can perform an extra pressure just in case if we need an extra pressure.
Silvia, it's Marianne Brehmer here. Can you hear me?
Hi, Marianne. Yeah.
Hi.
Can you
Nice
hear me?
procedure. Also very elegant.
Thank you, Marianne.
I was wondering, what about, do you have any concerns about the temperature?
Well, of course.
Also, since you don't have any outflow.
Yes, I'm concerned about the temperature, I'm concerned about the intrarenal pressure, but we are working at very low power setting because how much is the power? 8 watts. So we know that the temperature inside the kidney increase depending also the power setting that you use. For sure, we have to study more about the concept of intrarenal pressure and temperature, and we need more studies for sure, comparing in vivo all the situations that we can find.
But is your irrigation room temperature or is it body temperature?
It's room temperature.
Mm.
Do you use differently the
Doctora
irrigation?
Proietti, buenos días. Le saluda Freddy Ramirez. ¿Me escucha?
Good morning.
Sí, ¿qué tal? Doctora, mi pregunta es esta. Buen día. ¿En algún momento contempló la posibilidad de poner una camisa de acceso, dado que ya tenía un catéter
Sí.
WJ?
I didn't understand the Spanish, sorry.
Sí.
You cannot hear.
Silvia, if you
Sí.
ever thought about putting an access sheet.
Yeah. So I would like, I wanted to place the ureter access sheet, but the ureter was really not compliant. So with also the 7-point French, I felt a little bit, I can go? Okay. I felt a little bit of friction, so I don't want to damage the ureter by using the ureter access sheet for sure. But usually I use it. I don't know if I answer correctly to the colleague.
Yes.
Okay, perfect.
Silvia.
Sí, gracias.
Silvia,
Yeah.
Daron Smith from London. Very nice skill taking out the stent with a basket. That was
hi,
quite
Daron.
special, very slick. We
I
liked
was
that.
lucky. I was lucky.
It's I think it's a golfing phrase, isn't it? The more I practice, the luckier I get. Anyway, you've clearly practiced that. How big was this stone? I missed that at the beginning part. What's its volume, or were you working from a diameter?
No, the volume was maybe from the OR they can help me, was the volume of the stone.
Because it looks quite spherical as
400
you're
millimeters
operating on it. So,
millimeters cubic.
but it just gives a bit of an idea, doesn't it, in the planning of how long this is going to take to dust it to dust.
Oh, yes.
You've got a nice
Yeah.
view, of course, and you can take the time.
We will decide together when we have to stop. For sure, we cannot proceed longer because we don't have the ureter access sheet for sure. So let's see. Maybe we are inside the kidney since 10 minutes, no more, I think.
Yeah, it's quick.
But it could be, yes, a good point when to stop the procedure. But the other solution, for sure, could be, in my opinion, to perform a mini perk because this lady had the stent already inside. So if we place the stent again, I think the ureter will not be compliant enough to perform a flexible ureteroscopy with the ureter access sheet.
Silvia, what's your opinion about the
Yes?
new ureteroscopy, flexible ureteroscopy with aspiration system? Do you have any experience about it?
I think it's a good device that we have in our hands. I have some experience with the ureter access sheet with the suction. Honestly speaking, in my opinion, we need a device for suction. But in my opinion, we are a little bit not far away from the best solution for suction. I mean, with the ureter access sheet, we know that you have to be inside the kidney because otherwise the system does not work. And for many years, we said, don't place the ureter access sheet inside the kidney because the UPJ is the narrowest part of the kidney. And now we are entering inside the kidney because we need to stay inside the kidney with the suction device. And the other, if it works very well. But in my opinion, we still need to understand better how to modulate the irrigation and the suction, because if you have more suction than the irrigation, you can have some bleeding, of course, not really important from hemodynamically point of view, but it could be really annoying when you perform flexible ureteroscopy. So it's a good device for sure. And we need the suction because with this new laser that we have in our hands, we are producing more dust than in the past. We have also a flexible ureteroscope with suction. Honestly speaking, the scopes on the market that we have, I don't like a lot. Maybe we need a more efficient flexible ureteroscopes with suction because you can just aspirate dust, but if you have a small fragment, the system with the flexible ureteroscope will be broken or stopped by the fragment. So because the fragment is just stuck inside the working channel. So for sure, I am a supporter of the suction devices, but we need maybe something more efficient.
Silvia, this is Esteban.
Ciao, Esteban.
How are you? Ciao, ciao. So just a quick question. Can you tell us something about the laser and the power of the laser, or what are your settings for using a holmium laser, basically? And
yeah,
do you need
so you know that
yeah.
The holmium laser is the gold standard for lithotripsy. We have more lasers in our hands, but by the way, it works very well. We cannot complain about the holmium YAG laser. What is important, in my opinion, we don't need for lithotripsy, for the kidney stones, a very high power laser. For sure, if you perform also prostate, maybe it could be a good compromise. And I'm not an expert of prostate surgery, but I know that with this laser, the Jena surgical laser, you can perform also more sedation because it's inside the laser machine. So for prostate surgery, for BPH, it could be super useful. It's a very good laser. It's a holmium YAG laser. So now I'm working very low power settings for the reason that I told you before, and because I don't want to increase too much the power because I'm working without the ureter access sheet. So by the way, I work with now 0.4 joule and 30 hertz and long pulse duration.
Hi, it's Duvdevani.
Good morning.
Hello, Silvia. Can you hear me? Yeah. Hi, you're doing a great job. It's beautiful. I have a question. I see that you are dealing with a pelvic stone. So
Yeah.
don't you prefer to push it to any calyx, to walk inside a calyx for fragments not moving around when it's becoming small? I mean, do you feel comfortable breaking the stone here and not in the calyx? If you can, of course, if it's small enough.
Oh, it could be a solution, but honestly speaking, I don't feel that is moving too much. Well, of course, if I would need, I can move the stone in another. Oh, I have a fragment in another calyx. But by the way, I am in the lower calyx right now. Can you press the? Because.
Yeah, I see
Oh,
now.
no. I think I am in the lower part of the calyx. Only just a moment. Let's see. Sorry?
It's not the entrance of the calyx? Yeah, I think it's around the pelvis.
The lower part of the sorry, the entrance of the lower calyx. Yeah.
Yeah, I see.
You can see the X-ray.
Yeah, I see.
Yeah.
What I mean when I'm treating stones and start getting smaller and smaller, you have many fragments that you have to chase afterward,
Yeah.
and if you break it inside a calyx,
Yeah, but
stay inside.
yeah, it's a good suggestion. In my opinion, now they are going down, by the way, so it will be not difficult to find the fragments. By the way, I decided not to remove any fragments because the ureter in the distal part is not so compliant. So I will perform a popcorning technique, and of course, if there will be some remnants after flexible ureteroscopy, for sure, Professor Norberto Bernardo will decide what to do. So, wash a little. Okay.
Silvia,
Slowly.
después de
Yeah.
en este caso específico, ¿dejarás doble J?
Sorry?
Are you going to leave a stand after the surgery?
Absolutely, yes. I place the stent at the end of the procedure every time for a short time, but I never leave the patient without the stent. I know that if the flexible ureteroscopy is uncomplicated, you can leave the patient without placing the stent, but honestly speaking, I don't like it. So I place the stent all the time. For sure, in this procedure where we were not able to place the ureter access sheet, the ureter is not so nice. And also, I will have for sure some fragments at the end. So what is nice is that Dr. Sanguinetti, yeah, told me, so Silvia, do you want a stent before the procedure? I would say no. Because usually in our OR, we don't, in our hospital, we don't place the stent. For sure, this is a live surgery, and you don't want to have any problem with the ureter because you've never known. But you know, even though they placed the stent, the ureter was not so compliant. So for sure, you have to respect the ureter and to have, as I told you before, the plane B and the plane C every time available, because otherwise you will have you have to change the strategy along the way.
Silvia, it's Marianne again. Now, since you don't have an access sheath and you have all the dust in the renal pelvis, would you consider
I would say
having
also
a CT scan
fragment.
before you remove the stent?
sorry. Yeah, I'm sorry. I understood that.
Would you
in my
consider
opinion, this,
having a CT scan before the stent is removed, since you have all the dust left in the renal pelvis?
I remove the stent after short time, 5 days. But in this particular situation, of course, it's not my patient. I would say maybe it's useful to perform the CT scan with the stent inside, because I'm sure that at the end I will have some fragments. So I'm not maybe a good duster, but I'm doing my best.
I think you're an excellent duster.
Sylvia, Daron again from London. On that, dusting versus fragmenting, I think we've spoken about this. I'm a dust mentor. So dusting, as you were doing when the stone is whole, is rather more straightforward because it's bigger and you can leave it in one place, whether it's in the renal pelvis or a calyx. It's relatively easy to dust a whole stone. When it gets to the shell and it starts to fragment, dusting fragments is quite difficult, whereas removing them from a sheath is quite easy. So I'm a dust mentor, and of course that gives a specimen for analysis. So I like all of the things that you've said about being flexible, a plan A, a plan B, and a plan C. What about the specimen here? A specimen for culture, a specimen for biochemistry, tips and tricks, what would you do?
Yeah. So the patient has had the urine culture previously with Candida maybe, but she underwent the therapy before, and now the urine culture is negative. And so usually I don't perform any specimen of the urine during the procedure, but just the urine culture before I'm at my hospital. And usually I take one piece of the stone for the chemoanalysis always, but in this particular situation, I would say no. So let's change the settings in the other pedal. I would say 0.630. So look how much dust I produced. Stop irrigation. So here we have fragments, but before you saw how much dust we produce. Okay? Pietro, tell me when I can start again. Wash a little bit, Diana. Oof. Wow. Okay.
Hi, Silvia. Esteban again. Silvia, do you ever consider relocation of stones before starting dusting?
So, at the very beginning, I relocate every kind of stone in a favorable calyx, but honestly speaking, right now, I don't relocate anymore unless I have in the stone a very unfavorable calyx. But as you can see, I'm not doing any kind of deflection, strange deflection of the scope. And in my opinion, is a good calyx, this one, because you see, I am in the lower calyx, medium lower calyx, and I have all the fragments here, so I can perform the popcorning technique just here. So, do you relocate every time?
Yes, actually I do. I try to relocate all my stones in the upper pole based on some
in the upper pole. Okay.
There's good randomized control trials to increase stone free rate with that, and some better manipulations at some time, but it's fine. You're doing it.
Silvia, this is Glenn again. You're doing a great job popcorning the stone. Did you change your laser settings, and do you have any comments about that to get better popcorning,
so
to try
right
to get
now
everything into dust?
Okay. Right now I'm changing the settings for popcorning 1.230. 1.230 long pulse for pump corning. So the fiber, as you can see, just in the middle of the calyx. For dusting technique with the Olmium YAG laser, I usually use the low energy, the frequency around 20, I would say, long pulse duration. Wash a little bit in order to have, okay, stop.
Silvia, maybe I'm seeing that the kidney moves somehow. Do you use apneas? Can you comment on this?
Yeah, I already asked, sorry. I would need apnea, please. I already asked for decreasing the tidal volume of the patient. The patient is a little bit fat, so also for the anesthesiologist, it's not so easy to manage this patient. But now I ask for apnea. I am super demanding when I perform the lithotripsy, because if you touch with the laser fiber, the mucosa, you have some annoying bleeding, and you can have some problems in the visibility. So I prefer to ask apnea, but before asking apnea, because otherwise the anesthesiologist will kill me every time, I ask to decrease the tidal volume of the patient. Of course,
okay. So you like always general anesthesia, I imagine.
General anesthesia, always. I don't perform endourological surgery for stones and tumor as well in spinal surgery. First of all, because I don't like that the patient is awake, but by the way, you can perform a sedation, but is breathing too much. And so every time, 1-2 cases, I perform flexible ureteroscopy, spinal anesthesia. I regret to perform spinal anesthesia. And what do you do, Esteban? General?
Yes, I do exactly like you do. And I asked for apneas to my anesthetist.
You wrote also
I'm
paper
just
in Journal of
making
Endourology.
friends all the time, trying to for them to help me all the time. Yeah.
Wash a little bit, Elia. Okay. Wash.
It's an interesting one, the apnea. This is just talk in the background, Silvia. You can just concentrate on your pop dusting, because I don't use apnea at all. So actually for dusting, a little bit of respiratory movement can be quite helpful, because rather than yourself moving over the stone, you can just sit still and let the stone move to you, just little tiny wrist movements. My anaesthetist colleagues are quite happy to not do it, because they don't have then any rebound or pre-oxygenation. It's interesting that we've all got different approaches to the same problem, but on the same theme.
Yeah, it's interesting. Everybody has his habits in performing the procedure. Okay. So can you tell me the minutes, how long I am inside the kidney?
Sylvia, do you set a time limit when you're doing your ureteroscopy? Is there an absolute time that you say, I'm going to stop now and bring the patient back for a secondary procedure?
Yeah, absolutely. So I would say we can proceed at 5-10 minutes, according also to the desire of Professor Norberto Bernardo, and then I will place the stent. But by the way, the anesthesiologist is not telling me anything. I imagine that the patient is well. Yes, okay.
Silvia, it's Marianne again. When you don't have an access sheet, do you ever use a syringe to manually empty the renal pelvis during the procedure?
I've never done a procedure like this, because I don't like to aspirate inside the kidney, but could be a solution, but honestly, and never done. Wash. Wash. Stop washing. Okay. Cool.
Silvia, what about the scope? Do you usually use disposable scopes or do you ever use reusable? And when do you use each one?
I would say both. I am a super fan of single-use ureteroscope, but we cannot allow to use every time because we are a high-volume center. So according to our manager, in their opinion, we save money if we use the reusable scope. Wash a little bit. Okay, stop washing. So we use for difficult cases or when we perform a wash. Okay, stop washing. Okay, or ECRS or SBIS, simultaneous bilateral endoscopic surgery, because it could be helpful in the organization of the OR. But by the way, I am a super fan of single-use ureteroscope. It's super light. You have a very good image, and you have also the possibility to have in your hands every time a new scope with a very good deflection and so on. Okay. So X-ray. No. Wash and stop.
When
So
do you decide to stop?
We have a very... Sorry?
When do you decide to stop? I mean, when do you decide that the fragments are small enough?
Oh, it's a good question. So you have to compare to the size of the laser fiber. Honestly speaking, is not dust. I would say that if I was able to place the ureter access sheet, for sure, I would remove these small fragments by using the basket. But by the way, we already discussed, I don't want to use the basket in this case. Stop. Okay. Okay, wash a little bit. And when the fragments are floating around, by the way, they are small. But for sure, this patient is not stone-free. Is, I would say, quite stone-free right now from endoscopic point of view. But we have to perform the CT scan. Wash a little bit, just okay. Not bad, I would say. Okay. Super. Okay. Wash a little bit, Eliana? Okay. What do you think? From the audience?
I think it's
Hi, Silvia. Silvia, do you find popcorning to be easier with thulium fiber laser? Somehow more effective?
So, the TFL is a good laser for sure. For flexible ureteroscopy is a nice tool that we have in our hands. Honestly speaking, I don't think it's a very game changer of the flexible ureteroscopy. You can perform maybe more dusting, but honestly speaking, I prefer to use the TFL for sure. for the tumor. For the upper urinary tract tumor is my favorite, and also the thulium YAG, I would say stop. The thulium YAG, the pulse one, they are my favorite for the tumor. For the stone, I would say also with the Olmium YAG laser, watch a little bit, you can have a good result. So I think is enough. Watch a little bit. I would like to know from Professor Norberto or from the team if you are satisfied, because I want to finish the procedure. Okay. Okay.
We still have time, so
I will check the.
if you want, we can vote here. If the audience thinks that it's okay, raise your hand when people in the audience that think that it's okay. Levanten la mano los que piensan que terminó.
Can I make a comment?
Stand by.
Daron Smith again from London. I think, yeah, surgical-wise, Silvia, you've done a lovely job. And at this point of lots of dusting, you've got a bit of dust, you've got a little bit of blood. The ability to see the one tiny fragment that might remain is quite difficult. And I think here, like you were saying at the beginning, safety first. You've got an instinct that you've done enough. Nobody ever regrets that, but sometimes doing more can be a problem, particularly if she'd had candida before and any infection inside the stone. You never regret getting drainage and coming back another day if needed, and the patient can do some of the work in passing these stones.
But
I think your instinct to put a stent in is a good one.
Yeah, I want to point out also the compliance of the ureter. You see that I am with the 7.5 French, and the ureter is not so big as the guide wire, please, Eliana, from here, as we expected with the urethral stent inside. You have it? Okay. Tell me. Okay, perfect. Tell me. Okay. Okay, bye. Good.
Just to let you know, the audience thinks it's great too, so no worries.
Thank you so much. Thank you. So let's place the
That's good news,
guys. So irrigation, please. Irrigation, water. Okay. Oh. The guide wire, Paula. Like this. No, I don't need it. Okay? So when are female, I don't use the pusher usually, unless they are super. Okay. Bye. So continuously it's possible. Okay. Right, come on. Right. Oh, I think it's okay. Go down. Go down. Down the bladder. More on the bladder. In the symphysis, the centro, come si dice. Okay, a little bit down towards me. Okay, super. Okay. Continuously, guys. Okay, super. The bladder is full. So I will place the bladder catheter. I want to thank you and all the team for helping me and assisting me. Thank you so much. We finish. And so thanks again to Professor Norberto Bernardo for the prestigious invitation. Thank you. Bye.
Thank you.
Lovely job.
Thank all the moderators too. It was a great surgery.